Good morning. Today we'll be discussing Tommy John surgery and lateral epicondylitis. My name is Kentori Mitchell.
Andrew.
Good morning.
So the objective, students will be able to define the surgeries, describe the patient's indications, precautions, contraindications, mechanism, procedure of the surgeries, each phase of the rehab process, and then an overview and summary of the surgeries. Okay, so we're starting with UCL reconstruction.
So UCL reconstruction, which is commonly known as Tommy John surgery, is a procedure used to correct a torn UCL. And the injury is frequently seen in athletes, especially those with any kind of overhead motions like baseball or javelin throwing. And it utilizes a healthy tendon for repair, like the palmaris longus, the plantaris tendon, and the big toe extensor. Conservative treatment may be trialed before surgery, and there's a high return to play rate after surgery.
Okay, for indications, the condition that this surgery would be for would be UCL injury. Patients would be between the ages of 20 to 25. The mechanism of injury would be excessive valgus force to the medial compartment of the elbow. The area of symptoms would be the ulnar aspect of the elbow. It's aggravated by valgus stress of the elbow, throwing and pinching. Observation would be any bruising over the ulnar aspect. Active range of motion would be painful with full extension. Passive range of motion would be the same, so passive extension of the elbow and valgus stress. The infield depends on severity. Resisted to the elbow is usually remarkable. The special test would be the valgus and moving valgus test. Tenderness on palpation would be the ulnar aspect of the elbow, and in order for diagnosis, imaging would be made, so radiographs and MRI.
Right, so some of the UCL reconstruction precautions before surgery should include patient should avoid any valgus stress to prevent further damage to the ligament itself. Focus on maintaining the range of motion and strengthening the surrounding musculature around the ligament. Then they should practice some conservative management like non-steroidal anti-inflammatory drugs, bracing, and then even cryotherapy, like we learned about ice massages and Therax because it's a smaller surface area. Then the post-surgical precautions would be to immobilize. Immobilization is necessary initially to allow like healing. Avoid active range of motion at the elbow as well as any valgus stress, and then continue pain management with like the NSAIDs, and then early rehab would focus on the range of motion and to prevent stiffness of that joint.
All right, so some contraindications before surgery would be unable or unwilling to follow the post-rehab protocol. And then people that are at higher risk to anesthesia complications, those that have allergies to anesthesia, heart disease, or lung conditions. And then after surgery would be activities like valgus stress to the elbow, excessive shoulder movements, especially above 45 degrees of external rotation, strength and exercise, and then strenuous activities.
Okay, and I have a video to basically explain everything from this slide of the presentation.
Or from a deceased donor, allograft. The most frequently used tissue is the palmaris longus tendon in the forearm. The basic steps for UCL reconstruction surgery includes the following. The surgery is performed in an operating room under regional or general anesthesia. Your surgeon will make an incision over the medial epicondyle area. Care is taken to move muscles, tendons, and nerves out of the way. The donor tendon is harvested from either the forearm or below the knee. Your surgeon drills holes into the ulna and humerus bones. The donor tendon is then inserted through the drilled holes in a figure 8 pattern. The tendon is attached to the bone surfaces with special sutures. The incision is closed and covered with sterile dressings. Finally, a splint is applied with the elbow flexed at 90 degrees.
So for the UCL reconstruction rehabilitation process, of course, it's divided into 3 phases. So for the maximum protection phase, around like 0 to 6 weeks, the goal would be to protect the ligament, reduce pain, and prevent atrophy, just to name a few. Some interventions would be like immobilization, the RICE acronym, early range of motion exercises, and then like isometric strengthening. The precautions would be like no active elbow flexion extension, and then no valgus stress as well. Then for the moderate, some of the goals would be to protect the ligament, reduce pain, but gradual restoration of full range of motion, controlled strengthening, and continued graft protection. Then some key interventions would be progressive range of motion and active assisted range of motion, and light resistance exercises, just to name some. Some precautions would be no throwing or overhead activities and avoid heavy lifting. And then for the minimal or chronic protection phase, the goal is to restore full strength and function, gradually initiate return to work or sport activities, and ensure the graft is stable. Then some key interventions would be advanced strengthening, functional and specific training, even some core strength and proper body mechanics. And then precautions would be to monitor for any signs of pain, instability, and avoid full return until you're like cleared by your
Okay, now we're gonna get into the tennis elbow release.
So lateral epicondylitis or tennis elbow is usually caused by the breakdown of tendons in the lateral part of the elbow. And it's commonly seen in individuals who frequently use repetitive arm motions. This also includes baseball players, swimming, or people that weightlift. The release can be performed with two different techniques, either open surgery or arthroscopic surgery, and both procedures involve releasing the extensor carpi radialis brevis tendon, origin to relieve the pain and restore function. And for outcomes, about 80% of patients experience significant improvement within 6 months.
Okay, for indications, the condition the patient will have to have is obviously lateral epicondylitis. They'd be between the ages of 35 to 55. The mechanism of injury would be gradual overuse, which you just explained. Areas of symptoms would be the lateral aspect of the elbow. Symptoms are aggravated by wrist extension and grasping. Observation would be possible swelling on the lateral elbow. Active range of motion would be possible pain with wrist flexion, elbow extension. Passive range of motion would be pain on wrist flexion with forearm pronated and the elbow extended. There was nothing for the infield, and Dutton resisted would be pain on resisted wrist extension, radial deviation with the elbow extended, and pain on finger extension. And the special tests are those that we went over last semester, and tenderness with palpation would be on the lateral elbow, where the EDC, ECRB, and ECRL are, and then for imaging, it'd be radiographs and MRI.
Okay, for our tennis elbow release precautions, before surgery, you would like to avoid activities or provide some form of modification to prevent worsening the symptoms and aggravating the lateral elbow. So that would be motions like repetitive wrist extension and gripping. And then you would like to, manage your pain with ice or the NSAIDs and other modalities such as ultrasound or even ionophoresis. For Therex, you would like to practice eccentric strengthening and avoid sharp pain to elicit and eliciting exercises. Then you would like to brace and support like something like a counterforce brace or a wrist splint. And then you would like to educate the patient on activity modification strategies like I mentioned before. And then after surgery, splinting and immobilization would be for protection of that. You want to avoid lifting, gripping, and lateral stress again. And then control the pain and swelling with like cryotherapy and elevation.
So for contraindications for the tennis elbow release, before surgery we would have the mechanically restricted range of motion, those with neurological deficits, instability of the ligaments, fractures, just pretty much things that happen after a fracture, articular cartilage defects, loose bodies within the elbow, and then after surgery you'll have activities that increase pain or swelling, long distance traveling, and then strenuous activities and driving.
Okay, I have another video on the procedure.
Relieve pain and stiffness when injected to the affected muscle. Acupuncture treatment can help to reduce the hypertonicity of the elbow muscles. Surgery is considered as the last treatment option. It is recommended if the patient has unrelieved pain despite other treatments for more than 6 months. Surgical treatment options include traditional or open elbow surgery. It is a procedure where the ruptured tendon is detached and removed, followed by repair or reapproximation of the tendon. Arthroscopic surgery, a surgical procedure to repair the tendons where an arthroscope with a small camera on the end is inserted into the elbow joint. The camera displays internal structures of the elbow on a monitor screen, and your orthopedic surgeon directs the small surgical instruments to repair or remove the damaged muscle or tendon. Post
Okay, for the tennis elbow release rehabilitation process, for the maximum protection phase, the goals will be to protect the surgical site, control pain or edema, and prevent stiffness in the surrounding joints. Some key interventions for that time will be, of course, immobilization because it's the early stage, like a splinter dressing, manage the pain and swelling with cryotherapy, compression and elevation, and then gentle passive range of motion and active assisted range of motion. Precautions: avoid in-range movements, valgus stress, and lifting or gripping. For the moderate protection phase, goals will be to restore pain, free ranges of motion, initiate gentle strengthening, and protect the healing structures. Interventions will be progressive range of motion, incorporate active range of motion as tolerated, isometric strengthening, and then neuromuscular control retraining. And then for the minimal protection phase, goals will be to restore full strength and function, reintroduce functional and ADL specific activities, and then of course prevent re-injury or the symptom reoccurrence. Then the key interventions will be advanced strengthening and then functional return to ADLs.
Alright, so for the overview, UCL reconstruction is surgery that repairs the UCL utilizing either autograft or allograft. This is often indicated in athletes around 20 to 25, often due to repeated valgus stress, and the main goals of rehab would be to promote healing of the UCL, increase range of motion, and full return to work and or play. And this is all, most of this can be found with page 693 and 694. And then for the tennis elbow release, you have removal of diseased tissue around lateral elbow, often indicated for individuals around 35 to 55, often due to gradual overuse. Cosen's test and imaging for confirmation, and the main rehab goals would be decreased inflammation, improved flexibility, and return to work and or play. And this is on 698 through 699.
These are references. Are there any questions?
So for the elbow release, if the elbow is immobilized after the surgery, why is it recommended that long distance travel should be avoided?
Oh, you said why?
Yeah.
Just pretty much the general, that's like a general thing for most surgeries. They really don't recommend you like going up in an airplane after surgery.
I think this has to do with just like you don't want the stiffness.
Yeah, immobilized for sure. Any more?
I know there's a lot of new research on like Tommy John and especially baseball players. I was wondering during your all's research, did you find like a typical time frame now that people are saying like is the best for Tommy John for baseball?
For baseball, when looking at that, it's around 10 weeks, but it all depends how like the patient, 10 months, sorry, how the patient progresses, but usually around 10 months is what I read. Any more?
All right, thank you.
So, quick comments. So going back to the question that was asked about flying on an airplane after the surgery.
Right.
You can fact check me on this, but if, I think there's an issue with being at risk for blood clots
Yeah.
after having anesthesia when traveling at higher altitude. And so we don't want a blood clot to develop, nor do we want a blood clot to lodge to the lungs or to the brain or anything like that. Because you know that risk at higher altitude. Okay. Another thing too, after the person has the surgery and they're in a splint, right, with the elbow flex, if they try to use that arm to drive for a prolonged period of time, what is that gonna do with the elbow? That's gonna put it in extension, right? Typically when we drive, it depends on who we are. Like me, I sit with my seat far back, so my elbow is gonna be extended. Some of us sit like this, up at a wheel, so your elbows are flexed. So it just depends on how you drive and how you sit in your vehicle, you know. So, that's something you have to be aware of too, function, and if that function takes you out of the precautions that you have directly after surgery.
Yes, sir.